Aslam. So I think there has been a little bit of technology difficulty or audience. We have not everybody has been able to join, but I think it's about time we should start talking about restless leg syndrome. Just a little bit of introduction of me personally. I'm Munayar Khan, graduated from King Edward Medical School in Pakistan, and right now I'm working as Program Director for Sleep Fellowship at Hennepin County Medical Center, which is an affiliate hospital of University of Minnesota. So I do hybrid of neurology and sleep. And of course, wanted to give back to my country, and of course, we have been really very closely involved in this Apna Merit endeavor. So I've been in charge of putting together the course for sleep medicine. So please do remember to fill out the survey, and definitely you're welcome to post all your suggestions and comments and feedback, because we want to make it worth your effort and worth your time. This is geared towards fulfilling your clinical and academic needs. So it'll help us if you're able to guide us in terms of how would you like to have these talks in the future, if this has been helpful in your practice. So let's now talk about what we are planning to do tonight. Restless leg syndrome. The other proposed name of that is Willis Ekbom disease, because what has been suggested is that restless leg minimizes or trivializes the nature of this disease. So not many patients like to hear they just have restless legs. Goals of this discussion and the talk today is to advance the knowledge of Willis Ekbom disease and to improve the understanding of diagnostic and management strategies. At the end of this talk, I hope that you'll be able to define restless leg, apply the diagnostic criteria, detect the conditions associated with restless legs, and identify the diagnostic polysomnographic, which is basically the findings which we find on the sleep study. We are not going to go into too details of that. I think for those of you who might be interested in pursuing sleep medicine as a course, it's more relevant to them. But even in your general practice, even if you're seeing patients otherwise, it will come in handy. And of course, the main objective is to apply the practice management strategies effectively and to be able to know the adverse effects of treatment. So just a little bit of historic background. The name Willis Ekbom has been derived from two of the major worker and specialists who are pioneer in this field. Willis, Sir Thomas Willis, who's also well known for his anatomy definition of circle of Willis, and Ekbom, who was a Swedish neurologist. So to talk a little bit about diagnostic criteria, I'm going to just skim through some of these slides fairly quickly. If you have any questions, definitely ask at the end, or even you could write down in the chat, in the email box, the chat box, and Daniel can go forward those to me, and then in the end we can go through those. But I feel that probably you'll be more interested in the clinical management aspect, so we'll focus a little bit more on that. So when we talk about how to diagnose restless leg symptoms, there are three major criteria. The International Classification for Sleep Disorders 3, ICSD-3, defines three major criteria. It has to have urge to move the legs, which is typically accompanied by unpleasant, uncomfortable leg sensations. People can define it in a number of ways: creepy, crawly sensation in the legs want to move, or however they describe it. But basically, the urge to move has to be a core element of it. And then we can define that in order to try to elaborate a little bit more. Those urges to move the leg should be present or more prominent during rest or inactivity. So mainly you would notice the patients to complain then when they go to lay down in the bed, or when they have to sit for prolonged periods of time, like for example on a long car trip or on a long flight. And it's partially relieved by movement. So if they try to walk, of course this sensation is relieved to slight extent. It doesn't mean that it's going to completely go away, but temporarily for that moment it's partially relieved for some people. And it's worse, there's circadian rhythmicity to it. It's worst in the evening or at night. But the other two main criteria is that these symptoms should not be accounted for by some other disease process going on. For example, arthritic pain is not restless leg. Of course, arthritic pain is still pain, And because people are busy, distracted during their daily activities, they might feel like that it is more prominent at nighttime in bed. But that is something, of course, that depends. That is our duty as physician to tease that out. And the last criteria is that the symptoms should cause distress, or some sleep disturbance. Otherwise, if it's just some urge to move the legs without any consequence, we don't necessarily need to treat it. So the International Restless Leg Society group has also come up with the diagnostic criteria, but it's just a rephrasing of these criteria we talked about. We talked about the main three criteria with a little bit of elaboration of the first point, and the RLSS group defines it based on 5 criteria, which essentially involves the same features which we just talked about. I'm going to skip to specifier for significance and specifier for course. Basically, it just defines whether it's intermittent RLS or chronic persistent. So intermittent RLS will be if symptoms are present 2 or less than twice per week. Let me open up in the presenter mode. Okay, so that gives you hopefully a better view. And chronic persistent basically is symptoms lasting or present more than twice per week. Additional features, I think this thing is very important that we have to keep in mind that they are just additional features. They should not be the main features. But the additional feature would be that, because of the restless leg symptoms, patient is having resultant steep onset or maintenance insomnia. That either these urges to move the leg are so strong that they're keeping them from drifting into sleep, or if they wake up to do something to go to the bathroom, then the urge kicks in again, and then they have a hard time relaxing and being able to go back. And the other thing is they are frequently associated with periodic limb movements. But please remember that the presence of periodic limb movement does not need treatment by itself. Only if they have distress in terms of sleep onset or maintenance, then it needs treatment. The other thing very important to keep in mind, especially when the patients are giving us history, is to differentiate it from mimics. So many people, if we ask them if your legs are restless, if there's any discomfort, a number of other reasons can cause discomfort, but that does not define restless leg. So, of course, muscle pain, myalgias, leg cramps, arthritic pain, leg edema, positional discomfort, and neuropathic features. And some people have just habitual foot tapping. When they're sitting, some people might just start rocking their foot. It does not necessarily mean that it's disruptive enough or it is RLS. So these are the things that we have to keep in mind. And a few other things which sometimes might make it difficult to tease apart whether it's truly Willis Ekbom or whether it's just something else. So I think a few points which we'll go over is, can restless leg be painful? So typically pain is not the core feature that the patient should come or present with. But sometimes the discomfort can be so prominent or so bothersome that it can feel like as if the legs are hurting. But if that is the case, we need to really do our due diligence and make sure that it's not arthritic pain, or it's not fibromyalgia, nocturnal leg cramps, or the neuropathic features. What are the positive symptoms of peripheral neuropathy? So numbness, tingling, paresthesias, dysesthesias, those would be the symptoms. So we have to make sure that we have looked carefully at the other differential diagnoses. The other important thing is, can Willis Ekbom disease or RLS, restless leg, be asymmetric or present unilaterally? So typically it is present bilaterally, but it could be sometimes more prominent on one side as compared to the other, and sometimes it could even alternate. So, but occurring in one limb is rare. And again, we should exclude the other differential in that case. So now the last thing, is the urge to move essential? Exactly. That is the basic defining diagnostic criteria. So that has to be present. But like I said, unconscious, habitual leg or foot tapping or leg rocking movement, which can be discontinued, which can be suppressed, they are not restless leg. So The other supportive feature, which we talked about before, was relieved or partial relief by movement. So the question, many times you might come across people who say that, yeah, it doesn't get better. It doesn't get better if I walk or if I don't walk. But sometimes what their meaning is that if they start walking, and when they stop, it still bothers them. So it does not mean that walking will make it go away and then they would be, all of a sudden feel all better and have complete resolution. But what it means is that it partially, at that time, can lessen the urge to a certain degree. The other thing is that patients who might have very advanced and refractory restless leg, the relief with movement, the partial relief with movement might not be as prominent. And the last thing to consider is whether it's restless leg symptom itself or they have akathisia from the other medication they might be on. For example, the classic is antipsychotics, neuroleptics. Now, another diagnostic challenge I think which we need to talk about a little bit is difference between akathisia and restless leg. Akathisias, so how do we differentiate them from restless leg? So the key features are, number one, they're not worse with immobility. So remember when we talked about the essential criteria, that restless leg symptoms should get worse when somebody is immobile, but when they're moving, when they're walking, stretching, they get better. This is not the case with akathisia. If they're having akathisia type of movement, they would be restless, fidgety, whether they're sitting, standing, or walking. Akathisias are not relieved by movement. And the urge or their fidgetiness or restlessness, that is driven by an innate whole body discomfort or restlessness rather than by specific leg discomfort or limb discomfort. So a little bit about the demographics. The prevalence of restless leg is basically roughly 1.5 to 2.7-ish. And typically we define it to at least be present 2 days a week and having some impact, some clinical impact, causing some distress. Prevalence is about 1 to 2 weeks, or incidence is about 1 to 2 weeks. So incidence is new onset of the disease process in the population. If prevalence is overall occurrence of the disease, including the new and the old ones. So why is it important that we are talking about this in our discussion today? It can have significant impact on the quality of life. Of course, it's not as dangerous, if you will, as heart attack or atrial arrhythmias or stroke. But then if you think about it, it is a chronic condition for many people. And it really impacts quality of life, especially if it's disturbing their sleep, which is the common consequence. Anxiety and depression, it might be hard to believe, but I remember me meeting one of my patients who was a psychiatrist by training and who had such bad, horrendous case of restless leg that he stopped his practice because he could not sit still and talk to the patient when he would be sitting down, and especially psychotherapy sessions and other therapy sessions was extremely hard for him. And what he ended up doing was taking up motivational speaking. So he could, at least stand and, just pace around when he would be giving talk to his audience. But he gave up his clinical practice. Anxiety and depression, because some people are not able to enjoy, usual things in life, like long trips, sitting in front with a company. And the last thing is there's some evidence, it's not very well established, the evidence is sparse, that the increased incidence of restless leg symptoms could have increased morbidity in terms of cardiovascular disorders. So it is suggested, and I will show you in a slide. So this is one of the hypnogram for a patient. And as you can see, I'll just point out briefly, we are not going to talk in detail, but basically this is the oxygen saturation. This is the heart rate. And these are different stages of sleep. This hypnogram, this black is REM. And otherwise, this is wakefulness, this is N1, this is N2, and this is N3. So these are different stages of sleep. And these yellow markings right in the bottom, these are where restless leg symptom marker, which could be periodic limb movement, those are present. So here, some of the periodic limb movements due to restless leg syndrome are more clustered together. Here they are clustered together, here and then here. And correspondent to this time where the restless leg movements are clustered, you can see there's quite a bit of variability in heart rate. And then the cluster gets resolved and the heart rate becomes stable again. Here there's another cluster of PLMs and then the heart rate variability is noted again. So this is what is considered that probably because of sleep state instability and because of periodic limb movements, this causes a metabolic stress on the heart, which is shown in terms of this heart rate variability. Like I said, the evidence is still not 100% cemented, but clearly this is a real life example. So what causes restless leg? In some cases, it could be familial, meaning that there are some genetic links, not as strongly established, but there are some genes or some mutation which have been noted more in family clusters who suffered from restless leg. I'm not going to talk about which alleles, of course, because that is going to be going into too deep details of genetic and molecular biology. But they could also be idiopathic, that we don't know the cause, but it is there. And the last one is symptomatic. So symptomatic could be from basically from other etiologies going on. For example, some people with neuropathy could have also restless leg, but they would describe to you different features of restless leg other than their neuropathic pain. It could be although it could be hard to tease out, but some people can have both. So about familial RLS, typically that type of RLS, we note the age of incidence is younger than 50 years. Sometimes it could be adolescent age, and it could be even kids, although it's harder for them to describe and to express, but it could be present in kids too. 50% of all restless leg cases could be familial. There are some other conditions, physiological and medical conditions, which are also associated with restless leg. Pregnancy is, of course, a big one. Iron deficiency, chronic renal failure, peripheral neuropathy, like we talked about, and then I think a really common cause, which we tend to forget many times, is medication uses. So antidepressants, except bupropion, most of the antidepressants, antihistamines, and neuroleptics, mainly because neuroleptics have some antidopaminergic effect. So these classes of medication can definitely worsen restless leg and sometimes even unmask it. So also there's been now well-established data in terms of iron stores and restless leg symptoms. But when we talk about iron stores, it's not it's not hemoglobin level that has shown relationship, but it's mainly serum ferritin. Less than 45 to 50 micrograms per liter have been well correlated with not just the severity of restless leg, but also they have shown to impact the sleep efficiency. So sleep efficiency basically is defined by the total amount of sleep divided by the amount spent in bed. And decreased serum ferritin have shown also decreased sleep efficiency. So if you remember the serum ferritin levels from medical perspective, if they're in high 20s or 30, that is normal. But in patients with restless leg, higher levels have shown resolution of symptoms. There have been also some findings in terms of patients who had restless leg symptoms and on autopsy cases. In MRI also, some basal ganglionic changes have been seen in terms of reduced iron, but autopsy studies have also shown that the basal ganglia in RLS patients had decreased iron. So that sort of corroborates the fact that iron, of course, is heavily involved. Now, clinical approach. What are the other features that are important when we are asking patient about the history? Whether they have any family history of relatives being affected also with restless leg symptoms. Pregnancy, of course, like I said, that is very closely associated, has strong association. Anemia, of course, patient is not going to tell us whether they have anemia unless if they know it already or if they have been diagnosed. But in terms of history, any chronic or acute cause of blood loss, gastrointestinal or vaginal, predisposing factors to GI blood loss. Of course, we need to make sure that we screen those patients and if there's been any history of repeated blood donation, and symptoms of peripheral neuropathy. That's big, maybe because of my neurology background. I think that is a big one for my patients. And the use of medication. It's fairly common. Patient might be on Reglan, metoclopramide, which, of course, from the antidopaminergic effect can worsen these symptoms. Now, clinical approach. Of course, if we have such a patient in our clinical scenario, other than the history, we need to do a detailed neurological exam in terms of neuropathy. What investigations should we do? Serum ferritin should be checked, but the question always comes up, when should we check it? Some people propose that we should always check it from the get-go, because if we are treating somebody rather than giving them pharmacological agents that can have a higher side effect profile, if their ferritin is low, then iron replacement should be the first option. If we are suspecting that there has been some blood loss undetected, if a patient had restless leg, which was sort of well managed, but then they have noticed an increased worsening recently, or if the patient has a recent onset. Also, you could suggest that if there's been no response to the first drug, then we should check it. But arguably, if that's the case, probably, in my opinion, the first option would be to check the ferritin first, rather than trying a medication and then going back to iron replacement. One other important thing to keep in mind is that in chronic, that ferritin is also an acute phase reactant. So people with chronic inflammatory disease, be aware of that. And in that case, probably ferritin is going to be spuriously elevated. And you might think that, iron stores are at good levels. So in that situation, iron percentage saturation is a helpful marker, and we should absolutely get that. Let's skip over this because, of course, sleep study can be done to look for periodic limb movements. But remember that even if you don't find periodic limb movement, patient could still have restless leg. And this is just going through criteria for PLM scoring. I think I'm going to skip that and move on to the management portion. So this, I'll just briefly go through. This is a classic example of what a periodic limb movement looks like on this sleep study. This is a leg EMG lead, and you can see that, like I said, that there are certain criteria in terms of how much should be the magnitude and the interval in between. But you can see that the movements are fairly similar, and they have a periodicity to them. Now let's skip these two because I think, the most important thing is management portion. So the management part of Willis Ekbom disease is mainly divided into two main categories: non-pharmacological or conservative management, or pharmacological therapy. So when we talk about pharmacological, the main classes of medication used include dopaminergic agents, alpha-2 delta ligands, opioids, and benzodiazepines. And then we'll briefly talk about the perioperative management of restless leg. So in non-pharmacological, you could argue, other than the conservative, we could argue whether iron replacement is non-pharmacological or pharmacological, but that would be the mainstay. Before we move on to the other ones, if somebody has low ferritin, by low I mean, less than 50 to 75, then iron replacement should be the first trial. It is available in various forms: 325 milligram ferrous sulfate or ferrous gluconate or fumarate, BID or TID between meals. The reason between meals is that if we take it with meals, it can decrease the absorption. So that's important to remind the patients, because it is usually typically not taken that way. If they have some GI side effects, which is the main side effect of ferrous sulfate, or even the other formulations sometimes, but more so with ferrous sulfate, then we can try and either reduce the dose or we can allow them to take it with food. Vitamin C taken together with iron supplements can increase the absorption, and some of the formulations like Vitron C comes together with iron and vitamin C. Rechecking ferritin 3 to 6 months. If the facility or if the patient can afford to get the lab done, ferritin could be rechecked. Typically, I go by clinical response. If they're doing better, I will probably not check ferritin, but of course, I would like to at least do it maybe in a year or so, just to make sure that we are not overloading them with iron as well, which is typically not the case. Gold ferritin, should be above 50 to 75. Intravenous iron could also be given in form of iron gluconate or sucrose. Iron dextran has high rate of allergenic reactions. That's why it's typically suggested to try the other ones. But the thing to keep in mind is that intravenous should be done only when the patient cannot tolerate oral iron or has some malabsorption syndrome going on, that the absorption of it is affected if they take it orally. Other non-pharmacological strategies, I think they are overlooked frequently because we assume that the patient will have tried most of those. And sometimes they are trivialized and the patient feels that, this is not a treatment we are suggesting. But they can be hugely helpful. Walking, stationary bicycling, rubbing or soaking the limbs, close to bedtime can help. Walking doesn't mean that we should start doing brisk walk or, very heavy exercise, but, slight stretching would be helpful. Regular moderate physical activity earlier in the day, not at bedtime. If somebody starts doing rigorous physical activity, they might notice that initially their restless leg might feel aggravated, but then when they develop a moderate regime, then they would notice that it helps. Caffeine or stimulants, they should definitely not be taken in the last 4 or 5 hours before bedtime. And if they are on those incriminating medications, antidepressants, doesn't mean, of course, we have to weigh the risk and benefit balance. Maybe switching it to bupropion, neuroleptics, or antihistamines. Pharmacological management, let's talk about some of these classes we talked about. In terms of dopaminergic agent, the classic one is levodopa. So it is used for Parkinsonism, as we know, but it can also help with restless leg and can improve things. The response, the efficacy is noted right away when somebody takes it. But the other thing to keep in mind is that the side effect profile is kind of high. So augmentation is noted in 80% of the cases, as well as rebound is also one of the side effects. So let me clarify, what exactly do we mean by augmentation? Augmentation is different from habituation or, tolerance. Augmentation is more sort of like the reemergence of the patient's symptoms with a greater intensity. So basically it means that when the patient starts taking levodopa, initially they would notice that the symptoms get resolved, but then due to supersensitization of dopamine receptors in brain, the symptoms gradually over time, after initial relief, but then gradually when taken over time, patient notes that if their initial symptoms were starting at 8 o'clock, now they notice that the symptoms start progressing or creeping up earlier in the day, or the intensity of the symptoms becomes a little bit more. Or if they were localized only in the lower legs, they might notice that the now symptoms have involved other regions of the body, like even upper limb. Rebound is noticing the symptom earlier in the morning or earlier in the day, rather than the time when they are immobile in bed. So the next class, basically dopamine agonists, but the mainstay of treatment after the iron replacement have been classically dopamine agonists, pramipexole or ropinirole. Both of them are generic, both of them are FDA approved, widely available, highly effective. Of course, this table briefly relates about the pharmacological hemodynamics, metabolism and excretion, pharmacokinetics. But let's briefly talk about the side effects. The conventional side effects, which are noted very commonly, but in many cases they could be tolerable, but in some cases, of course, they can lead to discontinuation of the medication too. Lightheadedness, nausea, nasal congestion, and even leg swelling, leg edema, and constipation. Serious side effects, which definitely would make you think about, tapering the dose and trying another agent, include augmentation. So the incidence of augmentation, remember, with levodopa was 80%, but even with other regular dopamine agonists with pramipexole, it could be anywhere from 40 to 70%. The other main side effect that we need to keep in mind and screen the patients for, because they are not going to tell about this themselves, is impulse control disorder. So, and the third one is hypersomnia, excessive sleepiness. So augmentation and impulse control, both of these side effects, you will have to extract that from the patient. The patient is typically not going to volunteer or offer these themselves, because they think, for example, one of my patients started gambling. Otherwise, was a very good citizen, very law-abiding person, very gentle, kind. But then, all of a sudden, after taking this medication and gradually increasing the dose, he noticed that he would find himself going to the casinos and using the slot machines much, much more than what he used to do before. He hardly indulged in any gambling. But he felt embarrassed about it. He just thought that maybe it's him, didn't realize that it was the medication side effect. So, of course, this is the one where you have to ask. And the impulse control disorder could vary on a huge spectrum, from hoarding, cleanliness, hoarding, pathologic shopping, pathologic gambling. It could be a number of obsessive compulsive behaviors. Augmentation, we have already talked about it briefly, what it means, but how to treat it. Initially, it can be treatable by first splitting the dose. By that I mean if one patient is taking 0.5 of Mirapex or pramipexole, we can divide the dose. If their symptoms instead of 8 o'clock now start creeping up at 6 o'clock, we can give them 0.25 milligram at like maybe 5 o'clock if the symptoms, to try to nip the symptoms in the bud, and then the second dose we can give them close to bedtime. If we notice that there's progressive augmentation, especially at high doses, then we can consider switching to a different agent. So this is a graph showing patients with pramipexole. The augmentation rate was 42%. Now, there's also, other than pramipexole, Requip, the two agents which I showed. Rotigotine is a newer agent, more expensive, so of course, typically not used as widely, but it is available in a patch form, in a skin patch. So the advantage is that, if somebody has symptoms creeping up earlier, it will have, the blood level in the body would be uniform, and possibly so far less augmentation as compared to the typical dopamine agonist, although rotigotine is also a dopamine agonist. But as compared to Mirapex, pramipexole, and Requip, the augmentation is much less. The main common side effect of that is 27% of the people can have site reactions, the patch application site reactions. So impulse control, I'm probably going to skim through it too, because I want to leave some time for the Q&A as well, but these are the various impulse issues noted. The other class that I really want to talk about is calcium channel ligands, gabapentin and pregabalin. So I want to really talk about this and sort of try to drive the message home that this class of medication is also very effective for restless leg. And in fact, lately this has become more popular because, yes, this class has also certain side effects, but augmentation is typically not one of them. The main side effect of this class could be that patient might feel a little bit sleepy. It can cause a little bit of dizziness or unsteadiness, weight gain, and depression. But if you think about it, the restless leg symptoms are more prominent at nighttime. So if we are giving them nighttime dose, the symptoms we have to carefully monitor, not to give them any symptoms when they wake them up, adverse effect when they wake them up. But it is a very viable option. Mean dose which have been effective for the patient in terms of gabapentin are roughly 1800. But I would always start very, very low. In kids, even with 50, but even in adults, we could start off at 100 milligrams because some people can have benefit at a much lower dose. Pregabalin in doses of 300 milligrams have been shown to be effective, but of course, we have to be mindful of the side effect profile too. If these two classes fail or patient's restless leg is very refractory, then opioid can also be an option. Low potency agents can be used if they're intermittent. High potency agents we would only reserve for refractory cases. The main side effects of that could be nausea, constipation, itch, and of course exacerbation of sleep apnea, obstructive or central, and then drowsiness, CNS blunting, all that comes, and then habituation, tolerance, and then even addiction. But the thing is that the doses we need are very low as compared to the doses used in pain and for other issues. So for low potency medications, codeine and tramadol, 30 to 60 of codeine and tramadol of 50 to 100 can be very helpful. keeping in mind that the main side effect of tramadol is that it can lower seizure threshold. And then the high potency opioids include oxycodone 10 to 30, hydrocodone 10 to 30 at night, and methadone very low dose 5 to 10 is typically enough. And I would not go above these doses. Being very careful on following these patients to assess them for the risk of habituation or addiction. Benzodiazepines other benzodiazepines have been classically used, but they don't help in terms of the movement aspect, but they help more through trying to induce sleep. So they can be used as supplement or adjunct, but I would probably not use it as the main treating agent. Short-acting ones, zolpidem, Ambien is more benzodiazepine receptor agonist. It's not a classic benzodiazepine. But this one I would definitely avoid. This is not an agent I would give in patients because this has also been known to induce. So keeping in mind that we should avoid, not just because of parasomnias, but because of also worsening. But the other agents which are typically used are either intermediate or long-acting, temazepam or clonazepam. Clonazepam is the one which has been historically used, but of course, like I said, now I would hardly use it on a patient who comes to me. This is just a screen to kind of show you, to kind of walk you through. If somebody has intermittent restless leg, then the first step to do is to use the non-pharmacological therapy. And then if they are willing to go to the next step, if the non-pharmacological alone is not helpful, then trying the medication. This is, remember, only for intermittent, if they have symptoms less than twice a week. In that case, levodopa, if taken once or twice, is fine. But of course, I would not give these medication on a daily basis. Benzos, Klonopin, if only used for 1 or 2 days, that's okay. But low potency opioids, once or twice a day is okay, but I would never use it as an only agent. I would first go down the route of the other ones that we talked about first. So how would you choose between dopamine agonist or the alpha to delta ligands? If the patient has very severe RLS, then dopamine agonist can be effective right away. That would be an indication that maybe, they are so restless that we need to try to nip the evil right there. If they have comorbid depression, then of course we have to think about that. Obesity, metabolic syndrome, these are the cases where instead of giving gabapentin, they should be given dopamine agonist because gabapentin can also cause weight gain. Now, gabapentin and Lyrica can be given in those people who might have RLS but might have comorbid pain. For example, if they have radiculopathy, that could maybe, be killing 2 birds with 1 stone. If they have comorbid anxiety, then gabapentin can help with that. Comorbid insomnia, gabapentin can also induce a little bit of sleepiness. And if the patient has prior history of impulse control disorder or addiction, then instead of the dopamine agonist, then gabapentin or Lyrica would be a better choice. So this is also discussing about the same approach. Number 1, check ferritin first, just like we talked about. If somebody, and then move on to the other agents. If somebody has not only nighttime symptoms, but also now the symptoms have been happening in the daytime, then longer acting drugs could be used, like rotigotine patch. Not only is longer acting, it's also a patch, so that helps. For augmentation, initially split the dose, but then carefully observe, bring them back in for follow-up. And if the symptoms start progressing, then that's time to switch. Consider changing to another dopamine agent. That could be done if the first agent is unsuccessful or if the side effects are not tolerable. And the next step is, of course, changing to the other class. Now, if the restless leg is not responsive to a single agent, then we could consider a few of these strategies. Checking ferritin again. Maybe there was some other condition which aggravated things. Using combination drug management. So adding gabapentin to the dopamine agonist. Or eventually, as the third step, we could move on to the opioids. The other thing to keep in mind is that restless leg can be exacerbated after surgery because of the following number of reasons. typically they are NPO, they're getting their IV medication, but of course the medication for restless leg are stopped. So try to initiate all the oral intake as when they are safe as soon as possible. The other thing is somebody is in for a hip fracture plate, internal reduction or something, and they're immobilized in the bed. So of course, the more immobile they are, the restless leg symptoms would be more prominent. So of course, not in a patient who's not able to walk, but otherwise for other procedures, trying to sort of get them up there on their feet as soon as possible. If they are anemic because of massive blood loss during surgery, transfusion to try to bring the ferritin up. If they are nausea because of the opioids given for pain, if they have nausea, then instead of giving anti-dopaminergic, antiemetic medication like Reglan, metoclopramide, using ondansetron for nausea, and weaning of the opioids slowly rather than abruptly. So this is the last thing I wanted to show you. This is also a type of a conservative management. So this company came up with this Relaxus device, which is sort of just this mat, but you could call it, it is more sort of like a massaging mat, and which gives a little bit of tactile stimulation. This is a patient's legs, of course, who's lying on this mat. And through this remote control, it can be set up, the vibrations could be set up at various intensities. You can put it on timer and turn it on when they're going to bed. So maybe if they spend half an hour to fall asleep in bed, they'll just put it on timer. And then the mat will give slight stimulation, tactile stimulation to the leg, sort of like massaging, that helps prevent the urges to move. So although this agent, of course, comes with a price, but any neck massager or anything which can give them slight stimulation could be just as helpful. So I think because we started a little bit late, I want to give some time for question and answer session as well. And please keep in mind, definitely we'll skip the questions because I think answering your questions would be more helpful to you. But please remember, your feedback is very important to us. Anybody who might have some questions?